who managed to join us for yesterday's session, where we discussed about PACT initiative. We saw the tremendous achievement that this workforce has been able to do as part of the COVID-19 response. And we heard from our distinguished panelists, the former president of Liberia, Her Excellency Ellen Johnson Sirleaf, and the director of Africa CDC. For today's session, we are looking forward at compensation with a main focus on financing community health system for pandemic preparedness and response. We will be hearing from no other than the Deputy Director of Africa CDC, Dr. Ahmed, who is here with us today. Before we start, kindly note the following. The session will be for 1 hour, 30 minutes. We will have time for presentation as well as question and answer session. You are requested to mute your mic during the webinar if you have during the webinar, if you have a question, kindly write it in the Q&A box. The session moderator will raise it during the Q&A part. The session will be in 4 AU working languages: French, English, Arabic, and Portuguese. Kindly choose which language is your preferred option using the interpretation icon on the screen. Once again, we thank you for joining us to advance the voice of this very important health workforce in the pandemic preparedness and response. I was Deputy Director of Africa CDC. Over to you, sir.
Thank you very much, Mohammed. Good morning, good afternoon, good evening, colleagues, wherever you are joining us from. It is indeed a pleasure and honor to join you in this second day of this very, very important webinar series on cross-country learnings on community health systems, integration, and financing. So today I will speak about the importance of community health workers and use this as a case for sustainable financing. As we begin the conversation today, next slide. Okay, next slide, please. And as we begin the conversation today, the overview of what I'm going to be presenting is here. I will talk a little about community health workers in pandemic response, and then touch on sustainability financing and share some key takeaway messages from the presentation. Next. Next slide, please. Yes. So the reality on the ground here in Africa is that we have a very fragile and overstretched system. It's fragile because the base is weak. It is fragile because the middle part is weak. It is fragile because the support system, particularly financing in a sustainable way, is not yet achieved by most countries on the continent. If you look at just the health workers, the data that we have today indicates that we have about 2 health workers for 1,000 people, which is way, way below the recommended what the WHO recommends for health workers and the people ratio. Compare this with what we see in North America, where you have 25 health workers for 1,000 people. If we look at the budget, most countries are actually allocating less than 10% of their GDP to healthcare. And you will recall that the Abuja Declaration that had committed our countries through our heads of states to go beyond 15% mark, and this has not yet been achieved by most countries on the continent. In terms of facilities, less than half our countries on the continent actually have enough infrastructure that we can be able to call modern health facilities. This means that the healthcare that we are providing is being provided using infrastructure that is less than adequate, with less than adequate health workers, and with less than adequate budget to be able to deliver on the required service. Next slide, please. When we look at the skills gap in the public health workforce, we find that it is very, very significant. And I'll just use two examples to be able to show this. One is when you look at field epidemiologists in Africa today, we have just under 2,000 trained field epidemiologists, while our need is at least 6,000, which means we have a very large gap of 4,100 field epidemiologists. Now, when you look at the frontline epidemiologists, those who are really in the community responding to any threats in as far as public health is concerned, we have only 5,000 that have been trained, while our need is 25,000, which means we have a huge gap of 20,000 trained frontline epidemiologists. So in both cases, just using epidemiologists as a case for discussion, you will see that we are barely touching on 20% of our needs. Indeed, it's less in many other cadres of health workers. Now, when we look at community health workers specifically, and the map there on your left shows how Africa is faring when we look at community health workers on the continent. You will see that very few countries actually have greater than 2 community health workers per 10,000 population. Most are in the range of either less than 0.5 or up to 1. And this is a big concern because our communities in Africa, the best way to reach our communities is really through good infrastructure that is supporting community health work. Many countries around the world are using technology, but then that technology is still not very easily available here on the continent. Next slide. Now, all this we are doing in the context of the current pandemic. Next slide, please. And when we look at what Africa is experiencing during this very unprecedented pandemic season, you will see that we are undergoing the third wave. And since June, the numbers have been rising rapidly, and the case fatality rate, that is the number of people who are dying as a result of contracting COVID-19, is sustainable, has remained above the global average, meaning we are losing people at rates that are much higher than other parts of the world that may be seeing more cases of COVID-19. And this crisis means that we need to not only strengthen our health systems, but we also need to ensure that we are providing our future generations with an example of investment in health systems that can be able to tackle the real priorities on the continent. Next slide, please. When we look at this season of the COVID-19 pandemic, 3 things are very clear. One is that our health facilities have been overloaded because of the new numbers of COVID-19 patients who need hospital-based care. Now, this has resulted in disruption of services, including for endemic diseases that we've been struggling with for decades here on the continent: TB, malaria, HIV. Indeed, our immunization programs have also been disrupted. And this is because of the new numbers that are being brought in as a result of a COVID-19 pandemic. So the overloading of the health facilities has resulted in other services being disrupted very significantly. Secondly is our supply chain has also been disrupted. And not only because other parts of the world are facing the same problem, but also because our ability to be able to secure and procure the health products that we need has been reduced as a result of economic activities being affected by the pandemic. Now, this disruption in supply chain has therefore led to shortages, not just of COVID-19 products, health products, but also non-COVID-19 health products. So the supply chain really has been quite significantly hit by this pandemic. The third thing is our workforce shortages that we've had from before have become even worse now during the pandemic. And we see that our workers who are in the front line are not only getting infected by the virus, but some are actually losing their lives. And this is putting even more strain on the health workforce because we had few to start with. Our health system, because it is weak, is not providing them with adequate protection in terms of knowledge and other protective gear. And so, therefore, they end up getting infected and some are dying, and therefore the strain on the health system is even larger. Next slide, please. This comes at the cost of the communities in general. And the reason for focusing on community health workers is because we can be able to tackle some of those challenges that I've shared in the previous slide. We can be able to tackle that by using community health workers. For example, during the Ebola and Zika outbreaks on the continent, it was very clearly demonstrated that community health workers can be a very, very key tool for preparedness and response, especially where we are dealing with communities in the African context that are away from the urban setting. And we can use community health workers to increase access to health services, particularly the basic preventive, promotive health services that are very critical. Secondly, we can be able to provide our communities with culturally appropriate and culturally sensitive messages using individuals who come from within that same community. It's a very, very important and sensitive matter to take care of, particularly when we are having a large outbreak or a pandemic as we have at the moment. And of course, community health workers can also reduce the burden on the formal healthcare system, because if we tackle the problem at the community level and we are able to manage it at that level, then the rest of the healthcare system can actually be able to feel some relief, because everyone will not be coming to the hospitals and the clinics and things like that. So community health workers not only play an important role in preparedness and response, but they are a very critical part of our healthcare system infrastructure during times of emergencies and a crisis. Next slide, please. Now, as Africa CDC, we appreciate the role that community health workers play. And we have actually supported our member states during this pandemic time with community health workers. We have deployed over 18,000 in 27 member states. And the big work that they're doing can be seen in the number of households that they've been visiting during this period. Over 2.5 million households have been visited, messages have been passed, and very important learning has also been shared with the communities that our community health workers have been visiting. And in the pandemic response season, we deployed them to carry out contact tracing, particularly at the beginning of the pandemic when the numbers were still smaller. They were conducting contact tracing of COVID-19 cases and then creating enough awareness for those who have been exposed to go to hospital and get appropriate health care, and also for communities to appreciate that we can be able to reduce transmission. So they were providing very important information by engaging the communities. And now we have shifted their work to include the vaccine uptake that is so important during this time that we are rolling out vaccines. Next time, the next slide. Now, when we look at the financing angle of community health workers, there is a very clear case that we have a decent return on investment for community health workers in sub-Saharan Africa. When you have the proportion being 10-to-1, where you invest 1 and you get 10, really it is something that we need to be taking up a lot more than is currently happening. And we need to engage our countries so that they see that investing in community health workers is actually economically viable. Indeed, it is an effort towards having a healthier population who are then going to contribute to economic growth of a country. It is an effort to ensuring that we prevent outbreaks, we prevent future epidemics, and indeed it is an opportunity for us to be able to create jobs on the continent as well, particularly out in communities that are far away from our urban centers. Next slide. But when we look at the details of investment in community health programs, the picture is not particularly pleasing. Where we have our governments investing only about 40% of what has been in the total that have been invested in community health work, while 60% is still coming from partners. This means that this funding model is not sustainable, because if the partners were to remove their resources tomorrow, it means that we'll have a huge gap in our community health work on the continent. It is therefore absolutely critical that the method we use to fund and finance community health programs and activities need to be shifting towards being owned by national governments. We need to adjust the community health funding so that we use domestic financing more than we are using external support. Indeed, the good example from Ethiopia that we are going to be hearing about today is something that is worthy to emulate, where their health extension program has really attracted very good and positive attention as one way of government ownership of community health work. Next slide. Now, as I end my presentation today, I would like us to reflect a bit on some key takeaway messages. One is that community health workers programs is a smart investment. With a return on investment of 10-to-1, certainly it is something that we should not only be talking about, but we should be doing actively. In this way, we will be providing our people with information and the tools they need to protect themselves. We will be ensuring that our economy is not disrupted by outbreaks and pandemics and health emergency situations. Indeed, we will be contributing to Africa Union's Agenda 2063, which wants a better living environment for Africans on the continent. Second is that community health workers need to be fully integrated into the primary healthcare system. This way, it will enable governments to have long-term plans. It will enable governments to provide appropriate budgetary support, and it will enable this group of healthcare workers to be well-trained and well-exposed to all new material and information that is coming about the different types of healthcare challenges that our communities face. So we must invest in community health work within the primary healthcare system so that it is sustainable. And finally, is that we need to tell our own story. Our member states who have positive experiences, we need to tell that story ourselves. And our member states who may not have begun community health workers programs, we need to learn from our neighbors who are already implementing community health financing mechanisms that are working. And by learning from our neighbors, it means that we can be able to easily adapt what has been done in one part of Africa to another part of Africa. And in this way, we utilize our own lessons on the continent to improve the way in which we provide healthcare to our citizens. I thank you for the opportunity to speak today, and I'm looking forward to a very good second day of this high-level country learning on community health work systems and financing. I thank you.
Really, thank you. Big thank you to the Deputy Director of Africa CDC, Dr. Ahmed, for an excellent presentation, given the context of what community health workers can do on the continent and what they've been doing during this pandemic. I know it comes natural to you because for the greater part of last year, you were one of the biggest voice for community health workers on the continent, working very hard to ensure that Africa CDC deploy close to 30,000 community health workers across the continent, and for community health workers to be very active in the pandemic response. We thank you for all what you've done. We hear you, Deputy Director, what you said. Community health worker program is a smart investment, a real smart investment that African countries can benefit from. And with these words, it will naturally just take us to the next discussion. We will be very glad, maybe later, if you can join us if there are questions. But we will move now to the next discussion, which my colleague, Dr. Herlinda, will introduce us to the community health worker program on the continent. Thank you. Over to Dr. Linda.
So thank you so much, Dr. Mohammed, and thank you so much for the introduction. And again, my name is Dr. Herlinda Temba, the PACTA CHW Initiative Coordinator. And I'll be moderating the next two sessions. The first one on key takeaways from yesterday's session, and also the second one on a country's experience. And without further ado, then I'll call upon Mr. Tade Niyoyitungira, who will be taking us through the key takeaways from yesterday's session. Mr. Tade is a technical officer with the Division of Disease Control and Prevention at the Africa CDC, and he has been key in supporting the coordination of the PACT CHW initiative. So Mr. Tade, you have 5 minutes, and please turn on your video and take the floor. Thank you.
Thank you so much, Dr. Herlinda. Good afternoon, colleagues. As Dr. Herlinda has already mentioned, my name is Tade Niyoyitungira. I am a technical officer within the Division of Disease Control and Prevention at Africa CDC. Next slide, please. So I'm going to take you through the key takeaway of yesterday's session. For yesterday's session, we had His Excellency, Her Excellency President Salif and Dr. John as part of the panel. And also we had some testimonies from country representatives, namely the Republic of Egypt, the Republic of Cameroon and Uganda, who shared their success and of course challenges with regard to scaling resilient community health system for the COVID-19 pandemic response and control. Now, all the panelists yesterday, the topics was centered on the need for increased financing for sustainable community-based approaches. And all the panelists really agreed that we need coordinated investment that have really a result in compensated, protected, and digitally empowered community health workers that can serve for real-time epidemiological surveillance of infectious disease and day-to-day activities. And they really emphasized on community-based approach is very critical, is sustainable, and with guaranteed results for prevention, detection, response, and mitigation of health threats. Next slide. Yes. Now, despite all of these, they highlighted that there is a funding gap that is estimated at $2 billion of US dollars, of course, in building more resilient primary health system, despite the vision and political commitment. Talking about the PACT initiative, it has supported up to date 27 countries, and of course, over 18,000 community health workers were deployed in those countries to expedite member state response to the COVID-19 pandemic, including accelerating testing for case identification, contact tracing, and community engagement. And it was highly highlighted that community health worker programs are and will continue to be very important in the fight of against COVID-19 on the continent in terms of rolling out tests in the community while we secure enough vaccine. Next step. Now, from country perspective, though the workforce have achieved a lot, we still have some challenges related to capacity building of community health workers to sustain the health gains made by the PACT initiative. But also there is still a challenge on coordinating investment across different partners, I mean government, civil society organization, donors, to be able to sustainably scale high quality programs. But also there is still a challenge on integration of community health workers to the larger health system, of course, including creating a registry. But also there is still a challenge on protection of community health workers, this mainly on personal protective equipment, but also on vaccination. Next slide. Yes, we ended the session with key community health workers voicing the different requests where they called on the African Union, member states and donors first to prioritize their protection, their training, their supervision, and of course, the compensation. Yeah, I think that's the end of my presentation. For the yesterday takeaway. Thank you.
Thank you so much, Mr. Tade, for keeping time and for the comprehensive summary on the key takeaways from day one of this webinar. I believe now, even for those who were not part of our webinar yesterday, have had a glimpse on what was discussed. And now we'll shift our gears and hear from the three countries, that is Ghana, DRC, and Ethiopia. The three countries will be sharing with us their experiences in compensating the CHWs and also in financing to scale up CHW systems. For the country's presenter, we'll start with Ghana. Ghana presentation will be done by Dr. Barnabas Kwame Yeboah, the Acting Director for Nursing and Midwifery at the Ghana Ministry of Health. He's also the National Community Health Worker for Point at the country. Dr. Barnabas will focus his talk on the CHW compensation. Dr. Barnabas Boah, please take the floor, turn on your video, and start your presentation. You have 8 minutes. Thank you.
All right, thank you, Dr. Temba, and good afternoon, everyone. And thanks for the opportunity to make a presentation on behalf of Ghana. Please, the slide. Yeah, so I'm Dr. Barnabas Kwame Yeboah, as introduced. Next slide. Next slide, please. Right, so in line with my presentation, I'll be looking at the background of community health workers and CHIPS program in Ghana. As you all are aware, the concept of CHIPS, CHIPS and community health workers program emerged in the early 2000s. But before that, Ghana had already taken a policy decision to train and deploy community health workers throughout the country in order to provide primary health care services to our people. And this was called the CHIPS strategy. It's a flagship program that we introduced. CHIPS simply means community-based health planning and services. And this is done with the community in focus as the main focus for this program. So it became necessary and critical to expand the responsibility of community health workers through better training, better regulation, supervision, and remuneration. So Ghana adopted two main approaches. One approach is to have a formal training of community health workers as like 2 to 3 years. And we established schools all over the country, in all the 16 regions of our country, to train community health workers to be able to take care of the community services. So we have certificate program for 2 years, and we also have 3-year diploma programs. And the second approach was to have a short-term training because the 2-year, 3-year program were long. And for that matter, we needed a stopgap to train just few months to be able to serve the purpose. So those who were trained and certified and licensed for 2 or 3 years were graduated from schools. Almost every year we graduate about 2,000 of them from our training schools. And these are cadres that are employed permanently on government payroll, and they receive a compensation of not less than $266 monthly for their salaries. These are permanent employed people. As we speak, we have over 17,634 permanent community health workers on government payroll who take their salary every month. And then those who were recruited on the job started in 2005. We scaled it up in 2016, and we have employed over 50,000 youth in this program. And currently, as I speak, the government of Ghana, as part of its employment opportunity drive, is also recruiting about 20,000 graduates, unemployed people to provide community service, community health service. And the program is called NABCO, simply means Nation Builders Corp. Under this program, there are a lot of models that the government is rolling out. And one of the models has to do with healthcare, and that is that Heal Ghana. Under this program, Graduates are employed and deployed to the community to provide healthcare services for 3 good years. And after the 3 years, they are provided with a permanent employment. Usually when you finish graduate school, if you don't get a job, your skills are lost. So as a stopgap measure, government thinks that we needed to employ these people temporarily, let them get experience, and then we can integrate them into the healthcare system. Such people are taking about $117 every month. And there's a transitional plan for this cadre of staff. Next slide. So this is just to show you our CHIPS model, where in Ghana, we have the CHIPS zone. We have zoned the country into about 6,000 electoral areas, it's contaminated to electoral areas. And so every community has at least, we've zoned them into 750 households where we have a community health worker stationed with other community health workers. At least we are targeting about 3 community health workers taking care of this population, about 5,000 population of people within a central point where services are provided. And I can tell you this has provided a lot of leverage in terms of providing access to healthcare. And their work is to provide basic essential healthcare services to the community. And when they have challenges, they refer cases to the next level, which is the sub-district health center, and then to the district hospital as the referral hospital. Next, please. Yeah, so the objective for the compensation basically is to bridge the health worker population gap. Over the years, we have, as alluded by our previous speaker, we have critical shortage of health workers. And so the best way to provide primary healthcare services is to have this flagship program of CHIPS to get more people to reduce the health worker population gap. And then to increase access to health services for the rural poor, reduce youth unemployment, and improve socio-economic status. And of course, to also ensure sustainability of the CHIL and CHIPS program. Next, please. Next slide. Yeah, lessons learned. Since 2000, we had a lot of lessons learned. And one critical lesson we've learned is on political influence. The CHIL and the CHIPS program really has a very high political campaign issue. And any politician who would like to take the mantle of leadership, either as an MP, a member of parliament, or district chief executive, or a president, one of the campaign issue has to do with community health and CHIPS program. Without that, you might not be able to get some votes. So it becomes a very highly political campaign issue. And there's political will and commitment. I can say that our government, all previous government, current government, have been so committed to the CHIL and CHIPS program, especially because it brings a lot of employment. We observe increased government funding for PhD with donor interest as well. And then there's a link, a strong link between the people and politicians because of CHIL and CHIPS program. And then it promotes political will and cooperation between government agencies. We have had to work as a ministry. We work with the local government, private sector in ensuring that the community health workers have the right remuneration, they are well motivated and so on. And what is even intriguing is the fact that the community themselves donate resources to support the community health worker. Some donate their houses for accommodation, some donate equipment, some donate some compensation in kind to support the community health workers. We're able to do all this because we have well-structured steering committee at a high leadership level, represented from our presidency, the Ministry of Finance, as well as the local government. Next, please. Next slide. Yes, on access, one of the lessons we also learned was the fact that healthcare in rural community has become a top priority for governments and all our partners. We also observe an improved utilization of health services. It has also facilitated the advance of a resilient healthcare system in the community. Honestly speaking, had it not been the fact that we have put proper system in place as far as community health is concerned, this pandemic would have been a disaster, a more disaster for Ghana. But the moment this pandemic came, we activated and triggered all our community health systems, even though they were already working. We had to enhance their services as well. And the bedrock of all the work that we've done under COVID was centered or focused on. It also addresses inequity in health systems, and then it promoted the care of the aged and people in the life course approach through the community health worker. We call every. And one of the experience we also had has to do with e-health and telemedicine. Through community health worker programs, we were able to a lot of mobile phone services in terms of data collection, in terms of data analysis and so on, in terms of even e-monitoring, supervision of community services. And let me say that Ghana has been noted to be one of the fastest internet speed in Africa. This is a recent ranking. And we have leveraged on this kind of system to provide healthcare delivery through telemedicine, e-health to the community. And government deliberately invests in e-health. Socioeconomic lessons also ensure that we provided job opportunities for the teeming youth who are unemployed. And it has also brought ownership to the community health worker program. Next slide, please. Next slide. Yes, on national security, one thing we have learned is that community health is the bedrock of responding to any epidemic, disaster, or reporting. And like I said earlier, based on the structure we've put in place, we were able to seamlessly ensure that fighting COVID-19 was based on community health workers. And this has helped to reduce any health risk in the communities. And our community disease surveillance system have been strengthened due to the community health worker program in Ghana. Next slide. Yeah, definitely there are challenges. Like I said earlier, those who were recruited on the job, because of government tight budgets, sometimes there are delays in paying the community health workers who were recruited on the job. These are temporary workers, they are not the permanent ones. So there are issues with that. And then in recent times, those who are graduates, who graduate from the community health schools, government is unable to employ them immediately because of economic challenges we are facing now. So some have to wait for over 1 year, and this is posing a threat on their skills. And then our inability to reduce the annual intake of certificate programs. They've been called for us to reduce the numbers as far as training of the community health workers is concerned, because over the year, we've trained a lot of them in the system. But like I said, we are not able to put them on the permanent government payroll. So it's becoming a challenge, and people are calling us to do, but we are having a strategy to do health exports. I mean, where areas where we can help to have exchange program with other countries, and those that Ghana cannot absorb now, we can also export them to other countries to help. Next
So,
one.
Mr. Barnabas, please wind up your presentation. We are out of time.
All right, so these are just few recommendations. We are looking at reducing the annual intake of the program, and then prompt payment of our community health workers. And then we are calling on other countries to come to Ghana and learn from us. Thank you very much. Over.
Thank you so much, Mr. Barnabas, for that very comprehensive presentation. Can you confirm if we have Madam Emilia Tanye online so that she can share her experience as a community health worker?
Yes, she's online, so she can be called upon to do the presentation.
Okay. So, Ms. Emilia, please.
Hello, this is one of the interpreters of the Portuguese interpretation team. I have lost connection about half an hour ago, and I've been sending messages through to the panelists. Can you please assist me in getting back into the booth? I have to relieve my other colleague who's been speaking for 30 minutes now.
That is noted, Mr. Interpreter. Thank you so much. Then if we have Emilia online, please. take the floor and you have 5 minutes. Miss Emilia. Okay, if she's not ready now, we'll move to the next country, and that is DRC. So DRC is going to share their experience on compensating CHWs from the partner's perspective. And to do that, we have online Dr. Amede Yambi Mufu. Dr. Amede is a public health specialist, and he is a nutrition and a response focal point at Congo Caritas. So Dr. Amede, you have the floor and you have 8 minutes. Thank you.
Merci beaucoup Erlinda pour la parole. Nous voulons partager avec vous notre expérience par rapport à la rémunération des agents communautaires de santé communautaire ici dans notre pays. Comme vous le savez, vous avez là devant notre présentation, notre pays, la RDC, un si grand pays, mais ne détient aucun projet, aucun programme par rapport à la rémunération des agents de santé. Donc, ce sont des agents qui ne sont pas prévus comme agents directs du ministère de la Santé, et leur source de revenus dépend maintenant des agents, des partenaires techniques et financiers. Donc, ce sont des agents, comme vous le savez, vous l'avez bien dit, ils sont toujours au front pendant... Vous me suivez, j'espère. Vous me suivez, j'espère.
We kindly...
Vous me suivez, j'espère.
Allez-y, s'il vous plaît, Dr. Amede.
Oui, comme vous le savez, ce sont des agents qui sont toujours au front pendant les épidémies, pendant la pandémie actuelle. Ils sont toujours au front et par moments, ce sont eux qui donnent leur vie parfois. Ils sont contaminés et ils en meurent comme ça. Alors qu'ils n'ont pas, il n'y a pas une politique pour leur rémunération. Voilà notre partage, notre échange que nous voulons faire avec vous. La prochaine dia, s'il vous plaît. La diapo suivante, s'il vous plaît. Oui, comme nous avons dit que la RDC prend le volontariat. Cela veut dire que les agents de santé communautaire sont des volontaires. Les volontaires, c'est-à-dire qu'ils n'ont pas droit à une rémunération. Alors, comme nous le savons, ce sont des parents, ce sont des jeunes qui ont des projets d'avenir, ce sont des gens qui ont des familles qui doivent vivre. Dans notre pays, vous le savez aussi que nous vivons dans un contexte où il y a trop de chômage. Quand bien même il y a beaucoup de gens qui étudient, beaucoup de diplômés, mais sur le terrain, ces gens-là ne travaillent pas. La plupart sont comme les relais communautaires, ils nous aident. Ils travaillent avec nous dans plusieurs projets dont nous pouvons citer comme le projet PATC qui a été soutenu par Africa CDC. Et rares sont les agents de santé communautaire qui travaillent, bien que le gouvernement ou bien les programmes du ministère de la Santé tient à ce que les relais communautaires soient quelqu'un qui a une source de revenus, un travail, de manière qu'il puisse donner un temps de son travail, c'est-à-dire 1 heure à 2 heures. Alors que nous sommes face à des épidémies, face à la pandémie, qui demande à ce que les relais communautaires, les agents de santé communautaires soient permanents en train de travailler et donner plus de temps que prévu. Voilà. Donc, c'est ça un peu l'équivoque. Ce sont des gens qui ne sont pas payés, qui sont volontaires, mais alors qu'en soi, ils doivent vivre, ils doivent faire vivre leur famille, ils doivent faire étudier leurs enfants, ils doivent vaquer de leurs besoins un peu vitaux. Voilà un peu le problème. La dia suivante, s'il vous plaît. Diapo suivant, s'il vous plaît. Oui, Actuellement, dans notre pays, étant donné qu'il n'y a pas un programme spécifique pour leur paye, ce sont des partenaires techniques et financiers qui les appuient. Et ces appuis-là sont des appuis ponctuels qui viennent quand il y a des projets. Nous avons cité les projets de l'Union africaine que nous saluons. Il y a d'autres projets qui aident aussi les relais communautaires à avoir quelque chose. Mais quand on donne à un agent de santé communautaire, il y a des partenaires qui donnent 5 $ le mois, il y a certains qui donnent 10 $, il y a d'autres qui vous donnent peut-être 50 $. Et la CDC Afrique est allée plus loin, il a donné 90 $, ce qui a été vraiment salué par les relais communautaires. Ils l'ont même remarqué lors de l'évaluation ici, lors de leur passage ici pour l'évaluation du projet. Voilà un peu. Quand on donne à quelqu'un qui travaille beaucoup, qui sensibilise sur la pandémie, qui aide la population à comprendre la pandémie, à adhérer même à la vaccination, et cette personne-là ne reçoit pas grand-chose à la fin du mois. Voilà, parfois, ça entraîne un peu un déséquilibre, un découragement. Et de la manière que la plupart des relais communautaires qui sont actifs sont restés à la maison. Ils attendent assez qu'il y ait seulement le partenaire technique et financier soit là pour qu'il se pointe et travailler, parce que là, ils sont quand même sûrs qu'ils auront un petit rien, bien que ce n'est pas quand même suffisant, ils en ont quand même. Voilà un peu un élément très important. Alors, ces agents de santé communautaire travaillent, si aujourd'hui on est en train d'attendre que non, la pandémie, troisième vague est un peu maîtrisée, il y a des gens qui ont accepté, qui commencent à changer les comportements. Voilà, tout ça, c'est leur travail. Donc, ils sont en train de contribuer efficacement, mais au retour, ils n'ont pas grand-chose. La dia suivante, s'il vous plaît. La diapo suivante, s'il vous plaît. Oui, donc, comme on n'a pas beaucoup de minutes, c'est les défis maintenant. Qu'est-ce que nous pensons pour les agents de santé communautaire? Ce sont des gens qui doivent être valorisés. Ce sont des humains, comme nous l'avons dit, ils ont des familles, ils ont des enfants, ils doivent étudier. Certains sont des étudiants, d'ailleurs, parmi nous, les relais communautaires qui est avec nous, c'est une étudiante. Certains sont des pères de famille, certains ont des activités à promouvoir pour survivre. Voilà, c'est pourquoi nous, à notre pays, nous proposons, nous, en tant que Caritas, l'institutionnalisation de ces agents de santé. C'est très important parce qu'aujourd'hui, si nous avons tous ces résultats que nous sommes en train de publier partout, nous avons toutes ces statistiques, des chiffres par-ci, par-là, c'est grâce à ces agents de santé. Donc, leur intégration comme fonctionnaire ou bien dans le ministère de la Santé publique sera d'un grand appui, je dis, un grand appui pour ces agents-là. Et s'ils ont ne fût-ce que quelque chose mensuellement comme salaire, ils sont reconnus par le ministère, ça va encore les motiver. Et vous allez voir qu'ensemble, nous allons combattre plusieurs pandémies, plusieurs épidémies qui peuvent survenir dans notre pays. Ça, c'est le premier point. En plus, comme grand défi, c'est la coordination. Étant donné qu'il n'y a pas de motivation, il n'y a pas aussi une structure au niveau du ministère de la Santé qui est chargée de ces gens-là. Si on peut voir comment on peut créer une structure au sein du ministère de la Santé qui va s'occuper de ces gens-là, un programme, une coordination pour les encadrer, pour les aider, parce qu'ils ont quand même besoin de renforcement des capacités. Comme l'a dit notre prédécesseur, ce sont des gens, soit qui terminent l'université, soit ils terminent les études médicales ou bien infirmières, mais ils sont nulle part. Vaut mieux les utiliser comme ça. Alors, une coordination bien faite, une coordination bien tenue, ça va vraiment aider. Et on aura là cette fois-là, on aura à renforcer leurs capacités selon différents domaines. Et on n'aura plus, comme ça s'est fait dans certaines situations, les relais qui sont pour le VIH, les relais qui sont pour le PALU, les relais qui sont pour la COVID. Non, on aura des relais complets. On aura des relais communautaires ou bien des agents de santé qui auront à intervenir dans toutes les situations de santé qui va arriver dans notre pays. La dia suivante, s'il vous plaît. Les opportunités, il y en a. Des opportunités, il y en a. Il y a plein de partenaires techniques et financiers dans notre pays. Il y a les premiers, moi je dirais parmi la première opportunité, c'est l'Union africaine. Ça, c'est vraiment une opportunité que nous devons bien saisir. Parce que déjà, quand un bailleur, un partenaire vous propose et qui adhère déjà à cette philosophie, c'est déjà un grand pas. Donc, les partenaires financiers, techniques et financiers ne manquent jamais. Ils sont nombreux dans notre pays. Ils constituent une opportunité. Nous avons cité l'Union africaine. Il y a le Fonds mondial qui est avec nous ici. Il y a la Banque mondiale. Il y a les autres organisations, par exemple les organisations des Nations Unies, qui sont avec nous ici. Il y a nous avons cité aussi les groupes interbailleurs de santé. Ça existe ici dans notre pays, ces groupes-là. On peut faire aussi un plaidoyer. Ils constituent aussi une opportunité. Et à part ça, il y a le Parlement de la RDC. Ils sont là pour voter les lois. Donc, nous pouvons aussi faire un plaidoyer pour faire passer une loi par rapport ou bien en faveur de ces agents de santé dans notre pays. Donc, nous devons tous savoir que ces agents-là, ils ont un grand rôle à jouer, alors nous devons tout faire de manière que ces gens-là soient vraiment à l'aise, ils soient vraiment maîtrisés, ils ne puissent pas mal faire leur travail, qu'ils puissent bien faire le travail. La dia suivante, s'il vous plaît. En conclusion, comme recommandation, nous avons dit que nous le savons tous qu'ils jouent un grand rôle. Et pendant surtout cette pandémie de Covid, ils sont en train de jouer un grand rôle. Il y a certains parmi eux qui ont déjà donné leur vie à cause de leur position au front. Ils sont là, ils n'ont pas des épis, ils ne sont pas bien protégés, ils ne sont pas bien encadrés, ils ne sont pas bien motivés. Ils sont au front pour sensibiliser sur que les gens puissent maîtriser, puissent comprendre qu'est-ce qu'on doit faire pour lutter contre la COVID. Ils sont en train d'encourager les gens à adhérer à la vaccination. Alors, comme nous demandons l'institutionnalisation de ces agents communautaires, parce qu'il y a des avantages qui sont la valorisation. Une fois ils sont institutionnalisés, ils seront valorisés, ces agents de santé. Ils seront valorisés parce qu'en tant qu'humain, si chaque mois, on a un petit rien qui entre, on a un petit rien, on peut savoir budgétiser, on peut savoir faire un programme dans sa famille pour savoir subvenir à ses besoins. Deuxième, à part leur valorisation en tant qu'être humain, c'est une façon de valoriser aussi leur travail. Ils vont comprendre quand même que non, nous sommes là comme volontaires, mais voilà, cette fois-ci, c'est un travail qui est reconnu. Tout ce que nous sommes en train de faire est reconnu à tous les niveaux. Voilà. Et ça va aussi entraîner une stabilité. Une stabilité, c'est-à-dire un relais communautaire, une agence de santé communautaire qui a quelque chose mensuellement, il ne va pas aller chercher ailleurs parce qu'il sait que s'il fait bien son travail, s'il fait bien son travail, à la fin du mois, il y aura bien sûr quelque chose. Et la rémunération, c'est la valeur la plus importante, comme nous avons dit. Donc, nous tenons à ce que nous souhaitons et nous recommandons vraiment l'institutionnalisation de ces agents de santé par rapport à ce qu'ils font comme travail et par rapport à leur mission et les grands rôles qu'ils sont en train de jouer dans notre pays. Merci beaucoup. Merci, je vous remercie pour votre attention. Merci.
So thank you so much, Dr. Amede, for the presentation. You have exceeded your time, so straight ahead, I'm going to call upon the presenter from Ethiopia. And today we are privileged to have the director of the Ethiopia Community Extension Workers Program, who is going to share with us their experience in financing the Community Health Workers Program. So Dr. Ataro, please, you have the floor.
Thank you very much for this golden opportunity to share our country's experience to you and to learn from sister countries' experience. So can you please bring for the beginning slide? Can you make it back? Please, are you hearing me?
Yes, Mr. Ataro. It seems they removed the background slide. So if you can start from the slide that was projected. Sorry for that.
Okay, thank you so much. So I will try to explain shortly. Health Extension Program, what we call HEP. In Ethiopia, Health Extension Program is one of the most innovative community-based health scheme in the world as well. And the main strategy adopted with a view of achieving universal coverage of primary health care to the rural population especially. And it's defined 18 packages and essential promotive, preventive, and curative health services. Together, households will benefit from MCH, disease control and hygiene and sanitation program. And the philosophy is also, if the right knowledge and skill is transferred to households, they can take their responsibility for producing and maintaining their own health. And it is started in 2003 and piloted, then it is cascaded and launched in 2005. Then it becomes expanded to pastoralist in 2006 and to urban in 2009. And also it is included and expanding the community engagement and the participation. What we call a Women Development Army is initiated in 2010, and a second generation health extension program, what is included some curative part, also included in 2017-18, and currently we have developed 15 years roadmap of health extension program optimization, and we started implementation. Can we go to next slide? Next slide, please. The main actors of the health extension program are called health extension workers. In our case, what you call community health workers are a part of a formal government employee. And the health extension is mainly financed by the government, donors, and the community. Government finances the program by covering salaries, training of all the community health extension workers, and the responsible for managing and supervising the program totality. So significant elements of the health extension program costs are infrastructure, what we call building of health posts, training, short and in-service training, including in-service training, what we call integrated refreshment training, logistics, and the salaries of the health extension workers. Community financial contribution to the program is often not in a monetary form, but it linked with the contribution such as health post construction, labor, food and accommodation activities. And for each of community health extension worker monthly salary ranges from 100 to 200 USD. And the current number of health extension workers in the country is 42,767 extension workers working currently. Next slide. So the government share in financing health extension program and the health center has been increasing, as you easily observe from the graph, over the year from 2.4 to 5 billion Ethiopian birr. However, the share of health extension program is spending from the total health expenditure decline, and the focus also taken to health center activities, and this is what we recommend to balance both of them. And the local level, most districts spend between 20 up to 14% of the overall government health expenditure on health extension program. Please, next. So the general government share in financing health extension program has been increasing over the years. Means at the beginning it is 13.7% in 2010 and 11 to 27% in 2016 and 17. However, still the donors contribution large proportion from the program implementation, as you easily observe. The government part increasingly from time to time, and the donor one it also shows a decrement, but still it has a line share. Next. When we see the spending by input type, the large majority means 62% of health extension program spending was related to drugs, supplies, and medical equipments, followed by human resources and infrastructure related expenses. However, the future there is a plan to expand the infrastructure and the human resources, by, as I earlier said, health extension program optimization, and we want to decentralize more activities to the community, especially harder to reach area. So the expenditure should be expected to be higher and higher. Evaluation that has shown that the health extension program is a very cost-effective and highly contributed to the improvement of primary health care, which has helped us to reach universal health coverage. Next. This is the key lessons. What I've learned is the meaningful community engagement there, engage and empower the community members as what we call Women Development Army, which had a very great hand to help the health extension workers' activity at community level. Community support and health extension workers set their priorities and solve the local problems by supporting health extension workers. The second one is integration into a broader health system. This is already introduced, and this addresses the challenges of sustainability faced by many community programs by ensuring high political commitment, coordinating national policies, and leveraging support from partners. Next. Government commitment in financing health extension program is really appreciable, and the salary of relatively better compensation mechanism, and the program operation, capacity building, supervision, logistics, and also incentive packages, which is based on practice, is also covered by the government. And the fourth one is a coordinated national policies indispensable for success of health extension program. This includes a civil service policy that mandates health extension workers are recruited as civil servants, vocational educational policies that makes it possible to do large-scale vocational training for short periods, and the health policies that introduce health extension workers as the new cadre and equip them with hardware through the capital investment, and also to boost their career. Currently, we have, as a ministry, agreed with 8 universities to go their career to a degree program, what we call family health professionals. As I earlier said, we started to launch and practice health extension program optimization and increasing the rate at which domestic financing scheme substitutes the donors with the ambitions of the ensuring financial sustainability of health extension program, and consider the alternative sources of financing for health extension program packages, including health insurance. Next. Thank you so much for this opportunity. Dr. Herlinda, over to you.
Thank you so much, Dr. Ataro, for the great presentation. And I believe from the 3 countries, our participants have had a chance to get some experiences from the different countries. And now I wish to turn over to my co-moderator, Dr. Angela Gichaga, the CEO for Health Financing Alliance, to take over the moderation. Dr. Angela, please, you have the floor. Thank you.
Thank you so much, Dr. Herlinda, and thank you everyone for your attention until this time on this particular session. It has been and continues to be a great 2 days of engagement. As much as we interact and work with our government colleagues and partners on a day-to-day basis, there is really true value in pausing, intentionally listening and learning from each other and learning together. The goal of our webinar series was really to make sure that we share, we learn, we improve, and we grow together. In this session that I'll be moderating, we'll be seeking to clarify on the presentations that we have just had from our colleagues from Ghana, DRC, and Ethiopia, as well as synthesizing some of the lessons and learnings that we have gotten from the last 2 days. So this session will really be covering the questions for today's session, but the recommendations that have been gathered over the last 2 days. So I want to thank you for typing your questions and recommendations in the chat box. We have been gathering those in the background. We will try as much as possible to get to as many as possible during this session. That said, this is an ongoing conversation, which will continue in different other fora and sessions. We are going to publish an op-ed after this. We will be hosting a high-level roundtable as well. So there are going to be other opportunities to incorporate some of the learnings that we've shared today. We will also be deploying a poll at the end of this session that I'll be moderating. So kindly provide your feedback on the webinar series and helping us know what went well and what would need to be improved. So I'll start with the questions that came through the chat box. Again, thank you so much for typing those. We have a question for Dr. Ahmed. If you could please, I'll go through all the questions for the different speakers and then we will have them answer. If you could please, Dr. Ahmed, if you could please speak about what the new strategic plan to tackle COVID-19 in Africa looks like, and if you could actually touch on the HR and supply chain issues that you had alluded to earlier, and how that has influenced the new strategic plan to tackle COVID-19. So Dr. Ahmed, kindly note that question. It is for you. The second question I have here is from our colleague from Ghana. Thank you so much for teaching us a lot about CHIPS program that is one of the legacy community health systems on the continent. What triggered the CHIPS program to be a high political campaign issue? It would be great to learn as well from that experience in Ghana. So our colleague from Ghana, please note that question. It is for you. The third question I have here is for our colleague from DRC. Thank you for sharing your experience. The question we have for you is, how were you able to harmonize the community health worker incentives that are paid by different partners? You presented that there were some who are paying $5, $10, $80 and more. Have there been initiatives to try and harmonize that, and what experience has that been on ground? It would be great for our colleague from DRC to cover that as well. Ato Israel, thank you so much for that presentation as well. We are all and continue to learn as well from Ethiopia. A question from you is, we note that you do pay $100 to $200 for each health extension worker, which is great for motivation, and they are on payroll. How will you plan to sustain this motivation and sustain the overall financing of the health extension program into the future? So Ato Israel, please, if you could respond to that question as well. So we will go in that order in responding to the question. Dr. Ahmed, you may go first, and then we'll have our colleague from Ghana, our colleague from DRC, and our colleague as well from Ethiopia. Over to you, Dr. Ahmed.
I don't think Dr. Ahmed is still online. So if Dr. Mohammed can take that, thank you.
Dr. Mohammed, if you could respond to the question on the new Africa CDC strategy on COVID-19 and how it will address the HR and supply chain issues, that would be wonderful. Dr. Mohammed, over to you.
Yeah, even Dr. Mohammed is not online. So.
All right, d'accord. Merci, Fesh. All right, I will give the Africa CDC team a few minutes to come together and decide who could potentially respond to that question. But maybe we can move over to our colleague from Ghana to respond to his question as Africa CDC identifies who will respond to the first question. Ghana, how did you use community health and the CHIPS program as a political campaign, and what tips can you share with us?
All right, thank you very, very much, Dr. Angela. Yeah, so like I said earlier, the strategy for achieving universal health coverage and primary health care basically is led by CHIPS strategy. So as a technical group, we have made it a high political agenda and a buy-in by the politicians so that in their manifesto development, they could insert aspects of funding investments in CHIPS program and community health worker systems. So most of the health workers who are part of the political divide try to make sure that this particular emphasis is placed on their manifesto programs. And so when the politicians go out to do their campaign as a way of winning and the votes of the constituents, especially the MPs and the political leaders, they use that as a bait to attract their votes. So, and it has really paid off. And if you go to any community without a CHIP compound or a CHIP zone, then it means your MP is not working. So as a result of that, even our national health insurance scheme has provided special funding for MPs to be able to use the money to support the community health system in Ghana. So because of that, the politicians take it as an advantage to make a campaign promise so that when they come to power, they can use that money to support in community activities. So these are some of the trigger factors that has really caught the attention of our politicians. Thank you. Over.
Thank you so much for that response as well. Our colleague from DRC, if you could talk about harmonization of stipends, that would be very helpful. Kindly keep your response brief so that we can get through all the questions. Thank you.
Merci beaucoup, Madame, pour la parole. Il y a, concernant l'harmonisation des frais, d'abord, nous devons savoir que ce sont des partenaires qui ne sont pas venus, qui ne sont pas arrivés, ou bien qui n'ont pas intervenu, qui ne sont pas intervenus au même moment. Et ce sont les relais communautaires, les agents de santé communautaire, des volontaires. Un bailleur, quand il vient et dit « je propose ça », ils ne peuvent pas refuser. Donc, c'est pour eux un appui, alors qu'au début, il n'y en a pas. Donc, chaque bailleur vient à sa façon. Et c'est pourquoi nous sommes, au niveau des recommandations, nous avons prévu demander qu'il y ait une coordination qui puisse exister, qui puisse être créée justement pour coordonner tout ça. Comme ça, on saura que si un partenaire technique et financier vient intervenir, on va dire qu'il faudrait donner au relais communautaire X montant par jour. Pour le moment, c'est comme ça, chaque bailleur vient. Il y a des bailleurs qui viennent intervenir pour le VIH. Il y a ceux-là qui sont pour la tuberculose, et il y a ceux-là qui sont venus pour les CREC au niveau pour la lutte contre la COVID. Voilà, donc chaque partenaire. Mais une chose est vraie que les RECO sont contents quand ils sont devant en face d'un partenaire qui offre mieux. Ça leur permet de vivre. Voilà un peu. Donc, jusque-là, nous sommes au niveau d'une structure de coordination. Parmi les recommandations, nous les avons proposées qu'il y ait ça. Et comme ça, on pourra organiser ça à la longue. Mais sinon, juste pour le moment, chaque bailleur vient comme ça. Et ça crée un peu de frustration. Ça crée aussi par moment des résistances. Ils peuvent dire que non, tel bailleur nous a donné autant, vous nous avez donné autant. Voilà un peu. Donc, c'est ça un peu. C'est ça un peu qui nous dérange. C'est pourquoi nous sommes en train de plaider pour une coordination des agents de santé communautaire. Merci. Merci beaucoup.
Merci beaucoup, Monsieur Yambi. That's very helpful. And I think that's very clear. It's that journey to get to coordination, and thank you for responding to that. Ato Israel, s'il vous plaît, if you could respond to financial sustainability of the health extension program in Ethiopia. We are getting a few minutes to time. I do beg the indulgence of everyone on the call for an extra few minutes so that we can respond to your question and also highlight some of your recommendations. Ato Israel, over to you. Namasagnal.
Thank you, Dr. Angela. I think the sustainability issue of salary of the health extension worker is not that much very critical for us because it already systematized and they are payroll-based, the government employee. So there is no need of worrying about the sustainability of their salary. Not only that, we have also planned currently what we call HSTP2, and it is also included the salary of these health extension workers with also the performance-based incentives as well. So we have not that much the problem to sustain this payment of the health extension workers. Thank you.
All right, thank you so much. That is great. And it's fantastic that we've had from our countries. As I mentioned before, a lot of comments have been put on the chat box, and we have been monitoring and trying to summarize some of your recommendations. I will share some of the recommendations that have been shared in the chat box and then explain what the next steps are for these recommendations before I invite Ambassador Luis to close for us. So in terms of recommendations, we have overall recommendations on community health system strengthening, and then we have recommendations on the thematic areas that we were deep diving on during the last 2 days, which is integration, digitization, as well as compensation and sustainable financing. So recommendations on the overall community health system strengthening, a recommendation around leveraging partnerships and coordinated efforts both at the continental, regional, and country level has been proposed. There's a need to map existing community health resources, not just the community health workers, but the tools and the partners that are working in this space by type, by geographical scope, and by thematic focus area. And in addition to mapping, we need to also establish a database with all this information to streamline the way we run community health systems across the continent. There's a learning we've gotten also from the countries as well. Both Ghana, DRC, and Ethiopia have shared that the community health system developed has been changing, improving, and evolving over time. We need to recognize that the system needs to continue to improve and to grow, and this kind of conversations is what helps to improve systems within the country. So we need to be evolving our approach and systems on the continent over time to incorporate some of the learnings that we are getting. Another general recommendation is a comprehensive and streamlined approach to assess the progress, the impact, and the risks of community health systems is important, and we need to create feedback loops into the system. And this is very linked to improving the health systems as well. And we've actually seen the health impact of the systems across all the country presentations we had over the last 2 days. Cross-country learning opportunities and platforms should be increased, as this helps in the sharing of real and practical tips, not theoretical, but practical tips. Such opportunities are these webinars we have. I know Ghana has actually extended an invite to people to go and do some country exchange program and benchmarking. So we will be picking up on that invite as we get off this webinar. One of the other general recommendations is that community health systems provide significant employment opportunities, and thus this is and should be a political priority across the continent. So those are the overall recommendations around community health systems. More specifically, recommendations on integration. We have that integration of community health programs into the broader health system addresses the challenges of sustainability by ensuring high political commitment, coordinating national policies, and leveraging support from partners. The next is that we need to develop a map, good coordination, and an action plan for the different community-based surveillance systems across the continent and have oversight over these particular plans. We need to strengthen the capacity of health district actors to assess the risks of the public health emergencies as well. Recommendations on digitization, and we did learn a lot about digitization from our Uganda colleagues yesterday, is that there needs to be development of a country roadmap that standardizes and scales the integration of digital tools within the community health system. We also need to standardize the use and functionalities of these tools while we strengthen the data that is used and reported. There was also a recommendation from the chat box in terms of the need to explore offline digital tools as an alternative or a preferred option within countries because of the internet bandwidth challenges. Recommendations on compensation and sustainable financing, and we've had a lot of that today from our country colleagues, is that we need to, one, advocate to accelerate political momentum and financial support for community health systems. And actually, later on in this year, alongside the UN General Assembly, we do hope to co-host a roundtable with heads of state to have a political momentum as is indicated here. The second recommendation is to advocate for increased domestic and external investment in community health systems. We have seen that there is a $2 billion and growing gap. Actually, we updated, the Financing Alliance for Health updated the $2 billion gap analysis in 2020, and that gap has actually grown to about $4 billion per annum in sub-Saharan Africa. So we continue to update the knowledge pieces that we put out there. So there is a need for increased investment because there is underinvestment in community health systems. The third recommendation, and we had it from Ato Israel as well, is that the government's or domestic contribution share in meeting the costs of the programs should be secured, consistent, and increasing over time to substitute the high donor contributions. And then the last recommendation that we've been able to summarize from the chat box is that we need to consider alternative sources for financing community health, including health insurance. And our colleague from Ethiopia, as well as our colleague from Ghana, have mentioned this. I want to thank everyone for their attention during this Q&A and recommendation sessions. And I would like to invite Ambassador Louis Brown, who is the former representative of the Republic of Liberia to the United Nations, to offer his closing remarks. Thank you for your attention. Over to you, Ambassador.
Thank you, Madam Moderator. I think you've provided us quite a good bit of summary there. On behalf of the participants and attendees, I thank the African Union, Her Excellency, former President Ellen Johnson Sirleaf, Dr. John Ngengasong, and the Africa CDC family, as well as all of the contributing partners for this important effort to showcase the works of community health workers, share experiences, and advocate for increased financing for a community-based approach to public health delivery. This comes at an important time when many countries are experiencing a third wave of COVID-19 cases and are working around the clock to save lives, prevent further transmissions, and end the pandemic. Under the circumstances, it is tempting to only look inward, with each country concerning themselves with country-specific solutions. But as the global transmission escapes our individual borders, we are reminded that a truly sustainable response to global health threats must be collaborative. This can only mean strengthening and adequately financing the front lines in the prevention, detection, surveillance, and response to infectious diseases wherever they are, including in hard-to-reach areas. It means scaling up financing for public health, especially for community health workers, so that they are properly paid, trained, supervised, and integrated into public health systems. We can do this. We must do this. And so as we conclude, may I therefore join my voice to those of the many speakers before me in inviting all of us to embrace the lessons learned, accept the recommendations that have been forwarded, and importantly, turn our words into actions. We can begin to do this by prioritizing community-based health systems in national budgets, collaborating with donors to incorporate community-based approaches throughout the design and execution of health programs, professionalizing and protecting frontline health workers, including community health workers, to ultimately save lives and preserve livelihoods. Africa is still short on this commitment of 2 million community health workers. And given the update just provided by the moderator, has a funding gap of up to $4 billion. Challenging as this is, the collective message from the shared experiences is that we cannot fall short in our resolve to achieve the decision of the African Union, as well as to fund this important cadre in the health workforce. May I therefore encourage our leaders, as many have done before me, to one, align COVID-19 funding from domestic resources or donors to scale up community health workers for the COVID-19 response, who can then be integrated into the routine public health system. And two, make long-lasting public commitment to prioritize, increasingly invest, and uplift this crucial workforce that creates health, wealth, jobs, and security for everyone, everywhere. On behalf of all of us again, I thank the organizers and I thank all of you who participated from across the continent and from everywhere in the world. Thank you so much. Angela Isova, is back to you.
Thank you so much, Ambassador Brown, for closing for us. And this is just to say thank you so much to everyone who has joined this two-day webinar. We want to thank everyone that was involved. We thank the leadership of Her Excellency Ellen Johnson Sirleaf, Dr. Nkengasong, the Africa CDC team that have been very helpful. We want to thank the partners that supported this as well. We want to thank the Finance and Sustainability Subcommittee. We thank you for your time and your attention. We will keep the conversation going through the op-ed and the roundtable and on our social media pages. Kindly provide feedback on the survey and you may leave at your own pleasure. Thank you.
Thank you, Dr. Angela. Thanks, everyone. Bye-bye.
Thank you so much. Bye.
Merci, merci, au revoir.
Yeah, bye-bye.
Merci, au revoir. Merci.